Welcome everyone. We will be getting started in just a minute or two. Welcome to today's webinar. My name is Mary Smithick. I'll introduce myself properly in a moment. We do have a lot of people coming in, so we will give them a minute or two to make their way in, and then we'll be getting started very shortly. So we're just coming up to 1 o'clock there, but I can see there are a lot of people being admitted. So we will make just another minute just to give everyone a chance to actually be in, and then just in the interest of time, we'll get started because there's a lot to get through today. Okay, it's just gone 1 o'clock. I can see there are still people joining, which is great. There's a large number here. You'll see in a second now we have a really packed agenda, so we will get started. People will be joining, they'll all be missing my introduction, so that's fine, they won't miss anything too important. But a very big welcome to everyone here today. My name is Mary Smithick, Communications Manager with HSE Southwest. There are a large number of people here already, so thank you to all of you for making the time to join the webinar today. It's great to see so many. It's a really busy time for all of you, so it's fantastic that you're making the time in your diary to attend. And it's also great to see that we have colleagues from our Section 38 and Section 39 partners here as well. Absolutely delighted to have you here. In a second, I'm going to go through the agenda really quickly, but first of all, I want to thank the team involved in organising today's event. I get to swoop in at the last minute as MC and do the easy part for the hour, but there is a huge amount of work that goes on in the background to make an event like this happen, and also for it to run seamlessly. So a huge thank you to everyone in Change and Innovation who have been testing links and running test webinars and so on all this week. I won't be able to name everyone. There's a whole committee involved, but I do think I need to mention Sarah Cronin and Mary Flynn, who are driving the technical bus today, and we all know how nerve-wracking it is depending on technology, so thank you. Thank you as well to our speakers. We have a large number of speakers. You'll see when we see the agenda in a second. We're going to hear from our REO, our Regional Executive Officer. We're going to hear from our 3 integrated healthcare area managers. And most importantly, we're going to hear from representatives from each of the 3 IH areas. And it's really exciting that they're sharing updates with us, you know, on all the things that are going on across the region. So look, today is part of an ongoing process of engagement about the changes we're seeing in our structures. And as we get closer to March 3rd, when we fully operationalise the new integrated service design model and fully standing up the management teams in IHA. So this is an important part of the engagement, but it is just part of it. So obviously you'll be talking to your line manager, and there'll be a lot of other engagement going on as well. So just some housekeeping. As you all know, today's event is being recorded and it will go up on the HSE Southwest YouTube channel. So that means it'll be publicly available. For the smooth running of the event, your microphones are muted and your cameras are off. There's just too many of us to allow everyone to have the cameras on. I'm going to do one last reminder of the speakers. When you're not speaking, please turn off your microphone and your cameras, just because it'll help us to keep everything running as smoothly as possibly. We might move to the agenda there, just so everyone knows exactly what's going to be happening over the next hour or so. So very shortly, we'll have our opening address from our REO, Dr. Andy Phillips. And then Priscilla Lynch, the IHA manager for Cork South and West, is going to give us an overview of the ISD model for the whole region, for all of HSE Southwest. And we're then going to move to updates from each of our 3 IHA areas. So each IHA has a slot. We're going to start hearing from Cork South and West, then Cork North and East, and then Kerry. So in each case, the IHA manager will introduce the slot. They'll introduce their team, which is going to be very useful for all of us to know. And then members of the team themselves will talk us through really interesting developments in their area, which I think is what we're all looking forward to. And once we've done all of that, there's going to be time for some questions and answers. We're going to have a panel of the IHA managers, and they will be joined by our Regional Director of People, Deborah Harrington. So look, it wouldn't be a webinar like this if we didn't have some technical difficulties, and unfortunately, for some reason, the Q&A function is not working at the moment. I think that's a Teams-wide issue. So please continue to send your questions in to changeandinnovation.south@hse.ie. It's up on the screen there. It'll be going into the chat shortly, just if you need to be reminded of it. And the team there at Change and Innovation, they will be collating the questions and sending them on to us for discussion. Look, obviously, with so many people, we might not necessarily get to every single question, but the team will be looking at the questions, looking at the themes, and making sure that we're addressing the main themes. So look, note down the email address, changeandinnovation.south@hse.ie. And while you're doing that, I'm going to hand you over to REO Dr. Andy Phillips for our introduction.
Thank you, Mary, and good afternoon, everybody. I'm very aware that it's just about 2 years since I started as REO of HSE Southwest. What a magnificent 2 years that's been. And it's a year since we stood up the region. And over that time, we've been giving effect to Slauncher Care. You've all been working extremely hard. We've been putting some integrated services in place. But the 3rd of March really marks a point where we're fully embedding all of our management processes. We're moving into an integrated service delivery model. So I'd just like briefly to pay tribute to all those colleagues who so far have been involved in designing that. So in particular, the IHA managers, Priscilla, Julie and Sonia, who've been doing a magnificent job. And I'm very aware it means a lot of change for a lot of people, a lot of management change, a lot of clinical change, and we're doing things at pace. So without further ado, I'll hand over to Priscilla. Thank you, Mary.
Good afternoon, everyone. Thank you very much, Andy. Thank you all for joining us today as we continue our countdown to the 3rd of March, which is the next phase of the integrated health area journey. I would like to echo what Andy has just articulated and to acknowledge the significant work that everyone has already been involved and undertaken across the region. As you are all aware, Slauncher Care sets a very clear ambition: deliver services closer to home, integrate how we work, and ensure that care is coordinated around the needs of the patients that we every day come to work to deliver care to. What we are doing, I suppose, through the integrated service delivery model is central to achieving this ambition. I want to sincerely thank all the personnel and their teams right across the region for your commitment, your professionalism, and your really hard work. I would particularly like to thank the ISD leads, the heads of service, general managers, your leadership, your support, the enormous effort that has been involved in implementing this model. It is truly reflects your dedication and your collaboration, and we are really, really grateful for your support. It is important to re-emphasise the purpose of this change programme. It's not change for the sake of change, and those of us that have been in the service for many decades know that the organisation is very good at continuous change. The core objective is to improve care, treatment and outcomes for the patients that we serve. If I may move on to the next slide, please. So this slide actually depicts the services for IHA right across the region. And I suppose since the introduction of the IHA structure, we've commenced a regional approach to service delivery. This approach and the design is to ensure that we maximise out on the facilities and the resources available to us, to support us to reduce waiting times and to provide greater equity right across the services. An example of the regional approach that we have already undertaken are areas such as theatre effectiveness, endoscopy, oncology, single point of access for children, rehab services, diagnostics. That's just a few to mention. And a lot of you here on the call today and your respective teams are involved in those programmes of work. And it is taking that regional approach again, with maximising what service we have and improving how we deliver our services. And the areas that we're putting prioritisation to are very much aligned with our National Service Plan and our local operational plan for 2026. Really, this approach is strengthening how we will deliver our services in a more timely fashion, that we apply equity right across the region, notwithstanding that we have 3 respective IHA areas, and that we deliver a high quality services. Mary, I think had mentioned this already, but obviously the slides from today will remain available and will be circulated out. Obviously the recording from today will also be circulated out. And in addition, due to the non-functionability of the Q&A process, we will obviously keep that email open. So post today, most certainly outside of all the other communication factors, you will have an opportunity to pose other questions as well as they emerge. It is really important, I suppose, in terms of the opportunity that we have here collectively as a region to work as one team, right across all our disciplines, across our sites, across our services, and to deliver that responsive, high quality service that we all can be very, very proud of. If you wouldn't mind moving to the next slide, please. Thank you. So I'd like to acknowledge our regional leadership team. A lot of you are very familiar with our executive management team. However, given that today, 2 of our esteemed colleagues, Bridie O'Sullivan and Ger O'Callaghan, it's their final day with us. I would like to take an opportunity to thank them sincerely for their support, their very significant contributions to service delivery in the region over many decades, and to wish them both every happiness and enjoyment in their retirement. It is richly, richly deserved. At the same time, I would like to warmly welcome Nicola Brett, who will assume the role of Regional Director of Nursing and Midwifery, and Avril O'Sullivan as Interim Regional Director of Finance. We look forward to working closely with you both as we continue to build and strengthen our regional model. If I may, I might move on to the next slide, please. So as we establish our IHA management teams, it's really, really important to reiterate that this change programme is still in its infancy. Full population of our management teams and the implementation will take some time. However, it is envisaged that services will continue to develop at pace and continue in an integrated fashion. And it's certainly a great honour for us to be here with you today, and for our teams to articulate some of this work that has already been established. I want to take the opportunity, if I may, to reassure all personnel that existing terms and conditions will remain unchanged. As we transition to our new model and the governance structures, staff will be fully engaged with and consulted with through their line managers. We will continue to keep the clear communication and the forums that we have established. Obviously, a significant lens that we are placing on as an executive management team is not just the operational governance, but also the clinical governance and opportunities for staff working within the services over the coming years. This is truly an exciting time. It's one that presents real opportunities for service innovation, improvement and stronger integration right across our region. You'll see from the slide there, thank you, I think it's Sarah that's moving the slides for us. The time period has been significant, and Andy has outlined in his opening address. We are really moving at pace now towards the 3rd of March, where we will fully mobilise our IHA management teams. So it's with a great privilege that I am in the position today to be able to introduce my management team for IHA Southwest. And the slide here outlines the individuals that form part of my team. So I'll go in order of the slide there. So firstly is Jennifer Carney. Jennifer is CEO of Cork University Hospital. Next is Mairead O'Riordan. Mairead O'Riordan is Clinical Director of Cork University Maternity Hospital. Next is the CEO of South Infirmary Victoria Hospital, Helen O'Donovan. Next is Adrian Bradley, General Manager, Cork University Maternity Hospital. Next is ISD lead for South and West and older persons services lead, but also regional lead for palliative care, SLAs and grant aids, and that's Jackie Daly. Next is Annette Logan, and Annette is ISD lead for CHA 10. And is IHA lead for mental health services and Bantry General Hospital and 5 community hospitals. The next member of the management team is Mary O'Donovan, and Mary is IHA service lead for primary care. She is a regional lead for primary care, social inclusion, health and wellbeing and emergency management. The next post is vacant, so that feeds in terms of the timelines for the full implementation of our management teams. But that individual will hold a regional role for children's services and an IHA lead role for disability services in South and West. The next member of the team is Fiona Collins. Fiona is General Manager for CHA 11 and also has an IHA South Regional brief as GM for older persons or for mental health, excuse me. The next member of the management team is Sarah McAleera. Sarah is a General Manager in CHN 12 and is the GM rep for primary care and ECC in South and West. Our next member is Aisling Lenihan, and Aisling is the General Manager for CHA 13 and is the IHA South West rep for disability services. The next member of our team is Miriam Tobin. Miriam is General Manager for CHA 14. And Miriam is the General Manager for Southwest Representation for Older Person Services. Next member is David Lane. And David is the General Manager with a regional remit for social inclusion. And our next member of our team is Louise Martin. And Louise Martin is a General Manager with a regional lead for integrated flow. We're very fortunate to be supported by our business supports and by General Manager in my office, Joe Kirby, from the Director of People, Anne-Marie Byrne, Finance, Avril O'Sullivan, yet to be affirmed QPS Comms and Technology, but our esteemed colleagues on the Regional Executive Management team are supporting us until such time as those individuals have been identified. And then equally from a clinical support perspective, each of the IHA managers has an associated clinical director, and for South and West, that's Dr. Paul McMullen. So without further ado, it's my pleasure to hand you over next to Mary O'Donovan. Mary is going to give an overview in terms of some of the integrated working already established in South and West. So thank you so much.
Great. Thank you very much, Priscilla, and good afternoon, everybody. As Priscilla has referenced, I'm Mary O'Donovan, Head of Service for Primary Care and IHA Service Lead for Cork South and West. I'm currently Chair of Urgent Virtual Care, which I'm delighted to say is a regional service in operation over 15 months since November 2024. UVC was designed to support unnecessary ED presentations post-consultation between GPs or paramedics with emergency medicine, acute medicine and geriatric medicine, utilising alternate scheduled pathways where it's clinically appropriate to do so and where it's safe to do so. As referenced, referrals are via GPs and paramedics, with over 6,000 referrals since commencement, with data displaying a consistent 79% of ED avoidance. UVC is an absolute exemplar in showcasing the ISD model in action. Chaired by Primary Care, with representation from consultants in emergency, acute, geriatric, paediatric and mental health medicine, with our unscheduled care managers across the acute sites, clinical nurse managers, the integrated care programme for chronic disease and older persons, GP leads as part of the community healthcare networks, ICGP, SouthDoc and the National Ambulance Service. Other colleagues critical to the success and progression of UVC are academic partners in UCC, supporting the ongoing evaluation of UVC. Equally, our ICT, who have progressed e-referrals via HealthLink, data analysis, and of course our administrative colleagues who are critical to operations. We look forward to progressing UVC to phase 2, which will include paediatric pathways, nursing home supports, mental health liaison, and NEOC, or otherwise known as our National Emergency Operational Centre, where clinical triage teams will consider referral to UVC. UVC is currently operational 5 days per week from 9 to 5, with the intent to extend opening hours to a 6-day service in due course. Finally, I'd like to thank all colleagues who've worked tirelessly integrating services to make UVC a success and ultimately supporting service users to access the right care in the right place and at the right time to meet their needs. Thank you. At this point, I'll hand you over to Serka Kushik, who's going to speak about single point of access.
Thank you so much, Mary. So, hello everyone. Integrated working only becomes meaningful when families experience it. We hear every week families telling us that they struggle to know which door to knock on, and too often they're sent from one service to another. The single point of access has been designed to change that. Currently, access to children's community services, including primary care, disability services, and mental health is fragmented. Services have separate referral routes and manage their own waiting lists. This can lead to duplicated, redirected, or delayed referrals. Families may receive unclear communication, and referrals can move between services before reaching the right place. The single point of access is built on a no wrong door approach. If families, GPs, schools, or referrers are unsure which service is most appropriate, they submit one referral to single point of access. From there, it is directed to the right service at the right time. Single point of access provides a single digital access to point for all children's community referrals. Every referral is logged centrally, allowing duplicates to be identified early, progress to be tracked, and reducing the risk of referrals being lost. Clear referrals go directly to the appropriate service. Where there is complexity or multiple services involved, referrals can be reviewed by a multidisciplinary clinical review team, which has representation from all the 3 core services. Together, the representatives agree the most appropriate pathway, ensuring that there is consistency and shared responsibility. In HSE Southwest, the single point of access is operating as a demonstrator site in North Cork within community healthcare areas 4 and 5. The learning from this will now inform wider rollout as the referral pathways become standardized. The impact is already meaningful. Families are experiencing clearer communication and a more predictable journey. Staff involved are making shared decisions from the outset with clarity about care pathways, and the system as a whole is providing more streamlined and transparent access. Next slide, please. To demonstrate the real-life impact, I will now share a brief case example of a 6-year-old boy who was presenting with behavioural concerns, speech delay, and anxiety. Previously, separate referrals were being sent to multiple services. Each service received only part of the picture. This led to duplication, repeated redirection, and conflicting communication. Several services also declined the referral as not appropriate, despite clearly the child needing support. For families, experiences like this are stressful and confusing. Delays at this stage can also affect outcomes, particularly when early intervention is critical. Now, through single point of access, the same situation is looking very different. One digital referral is submitted and logged centrally. Duplicates are identified early. A joint triage between primary care, Children's Disability Network team, and CAMS allows services to review the full picture together and agree the most appropriate plan. In this case, the referral was directed to speech and language therapy and psychology within primary care, and it was jointly agreed that CAMS input was not required. The family received one clear communication outlining the plan and the next steps. Their stress was hugely reduced, and the child accessed the right service without unnecessary delay. This is the core value of single point of access: clarity, coordination, and compassionate access. Thank you so much for your time today.
Serka, thank you so much, and thank you to the team in Cork South and West, and particularly thank you to both Serka and to Mary for giving us those real tangible examples of what's going on the ground. Just a snapshot, we know, of all the good work that's going on across the entire region. We're now going to move to Integrated Healthcare Area Cork North and East. So I'm going to hand you over to Sonia Cotter, who is the manager for that IHA area. She will, just as Priscilla did, she will introduce her team team, and then she will hand over to 2 members of her team who are going to give us some more presentations. And the good news is we are running on time so far, so no pressure on the next few speakers, but everyone so far has done an excellent job. So over to you, Sonia.
Yeah, thank you, Mary. Good afternoon to all of you. So as Mary outlined, my name is Sonia Cott. I'm the IHA manager for Cork North and East, and I'm going to go through the team that's currently been for Cork North and East. So I'm delighted to have Margaret McKiernan on our team. She's currently CEO of Mercy University Hospital. The Mercy University Hospital, as you know, is a Section 38, but the relationship and collaboration that myself and Margaret have built up over the last 12 months will continue to ensure safe delivery care within the Mercy and the region to support that. Next, our IHA service lead is Deirdre O'Keefe. So Deirdre will be joining us over the next few weeks. Deirdre has a significant background in acute as well, and Deirdre will be taking the regional lead for acute services, but will also have a focus on disabilities and children. A lot of you will know and be very familiar with them. My next IHA service lead, which is Gabriel O'Keefe, and Gabriel has significant experience across all the care groups, and Gabriel will be a regional lead with an ISD focus on mental health, primary care and health wellbeing. My next third IHA service lead is currently vacant, and we will be interviewing shortly for that and hopefully have successful candidates. For CHA5, I have a general manager, Aileen O'Neill, and Aileen will take a regional, an IHA lead on older persons, where a lot of her background and history is with older persons. Next for CHA6 is Suzanne O'Sullivan. Suzanne will be speaking today. Suzanne will be taking a lead around primary care and health and wellbeing as well. I welcome Maria Moran to the team. So Maria will be joining us as General Manager for CHA7, and she'll be taking up her position in the next week or two. And Maria will be taking a regional lead on mental health. Next for CHA8 is Martina Corkery. Martina has a history in primary care, but Martina will be over CHN8 and also will have a lead in disabilities children's services. I'm very lucky to have, because of the acute services and the acute service lead, we will be doing 2 general managers are in place. The first is Darren Hickey. So Darren has a significant history around shelter care management. So Darren will be working with us from a regional perspective around the waiting lists and shelter care activity across all areas, including community activity. And we have a general manager, and we've confirmed Miss Hannah Healy, and Hannah will be joining us for a regional on shelter care. Our business supports, a lot of you will know Sheila Leopold. So Sheila is now the IHA general manager, and Sheila will be speaking to us today around how we take a regional approach to improving services for our areas. From people, Mary O'Connor is our business support. Kieran Cronin for Capital and Estates, and Kevin Buckley for Finance. And similar to Priscilla, we have waiting people to be allocated for QPS and Comms and Public Affairs. So thank you, Mary. I'm going to hand over firstly to Sheila. And Sheila's going to speak today about the regional strategy to improve systemic anti-cancer therapy. Thank you, Sheila.
Thank you, Sonia. Good afternoon, everyone. I'm Sheila Leopold, as Sonia said, General Manager in Cork North and East. I'm also the nominated Health Region Lead to work with the National Cancer Control Programme on the strategic plan for adult systemic anti-cancer treatment capacity for the South West region. I'm delighted to join you today to discuss an aspect of work underway where regional collaboration could bring us next. We will look at how we are addressing some of the capacity pressures within our SACT services in the region. And for today's talk, I will be outlining a subset of projects within the regional SACT strategy. There are several other work streams underway for further development and wider implementation. So if we go to the objectives, so the objectives today really was to implement a targeted improvement strategy to increase capacity across the region, to optimise our chair utilisation in our day units, to ensure that we have efficient delivery of systemic anti-cancer therapies across the region, and to address growing demand. And also to support a sustainable service delivery aligned with the National Cancer Control Programme. So the first thing we did there, if we go to the actions, was what we did to explore the collaboration across all sites to maximise treatment and patient flow. So we looked at the hospitals involved in the project. So we had Cork University Hospital, we had University Hospital Kerry, South Infirmary and Mercy University Hospital. So each hospital was delivering treatments to patients not originating on their site. So that did help out with sites under pressure and free up service delivery there. We then went on to do an audit of chair capacity and utilisation across the region, because whilst recognising that we did have an issue with capacity, we also needed to build on our capacity for future demand. So for this, we used an audit tool called the Capacity Insight Tool. It's a strategic directional resource designed to support SAC day units in evaluating their current capacity. The key features of this report will include current state analysis, which will provide a clear view of existing operations under current business as usual. And then also we can look at scenario modelling, where if we see an increase of 10% of referrals into the units, we can see what we can do to actually support all of those patients coming through. The key benefits to the patients will be reduced delay to treatment, thus reducing wait times, improved experience of treatment due to improved capacity, and a reduction in the on-day delays and deferrals, and a potential to standardise the practices of SAC delivery across the region. So this audit was completed in December, and we are hoping to have a full report on that at the end of February, and we will be presenting the report to the regional executive team then, and then wider distribution. So the next project we looked at was chemotherapy at home. And this really is in keeping in line the slow to care principles of keeping care closer to the home and in fact in home itself. So this project aims to enhance convenience for patients while supporting improved utilisation of hospital-based resources. The initiative will deliver Herceptin therapy in patients' homes and will reduce hospital visits, and this will also free up capacity within the day units in CUH. It empowers patients with greater convenience and control, reduces the pressure on SAC units and supports a more sustainable patient-centred cancer service. Future possibilities of this we will be able to roll it out to other hospitals in the area, South Infirmary, Victoria Hospital and University Hospital Kerry. So that's a very exciting project. We're hoping to get that underway end of Q1. So it's very good.
Sheila, we might just hopefully move on in the next minute or so. Apologies to interrupt. Thanks, Sheila.
No hassle. So our next piece is the systemic anti-cancer therapy outreach project in Bantry, which will also, in line with Sloan to Care ambition to bring care closer to the home. So I'll leave it at that. Thanks, Mary.
Good afternoon, everybody. My name is Suzanne O'Sullivan, and I am transitioning from my general manager post in primary care to a general manager post covering community healthcare area 6 in Cork North and East IHA. I won't keep you long now, as I know it's lunchtime. I would like to give you a brief outline of some of the feedback I have received from my team regarding the implementation of the ISD model, showing the benefits of the model, and thanks indeed to my team who prepared the slides for me. So the community healthcare areas have been building the foundations for integrated services over the last number of years, and the model supports these foundations. I am going to give a few examples to illustrate the benefits of this integrated model and integrated way of working. My first example sees every morning at 9:15 network managers, therapy representatives, community nurses, acute hospital staff, CIT and integrated operational lead attend the daily detox meetings for our IHA. There are different times for each IHA. These daily meetings facilitate and enhance communication across all services, assisting and leading to coordinated discharges. We also try to support difficult discharges, and the meeting allows an opportunity for staff to raise any concerns for specific patients. We try to support each other, the services, and ensure that the patient is receiving the right level of care at the most appropriate place. Another example, primary care centres are home to primary care staff, disability staff, home support staff, adult mental health staff, GPs, CAMS teams, health and wellbeing staff, admin staff who support schemes, etc. And I hope I haven't forgotten anyone. This co-location of care groups and services means that we share facilities, are adjacent to each other, allowing us to meet and build relationships, which enhances integrated working and communication about our patients. We also facilitate acute outreach services in primary care centres, such as maternity services and paediatric services, which hold clinics in some of the primary care centres, which is great for our patients. Less travelling, receiving services closer to home, which underpins the Sloan to Care model. The benefits of the model ensure that all care groups understand each other's scope of practice, parameters of working, referral criteria, etc., i.e. the way we work. This affords staff a great opportunity to learn from each other. And I suppose we do talk about patients and shared care arrangements, and it facilitates a better way of outcomes for our patients. In addition, as there will be a single governance structure for each network, i.e. community healthcare area will now be managed by a single manager, allowing issues irrespective of care group to be jointly solved by all geographical stakeholders from the same area. I look forward now to lively management team meetings in CHA 6 with all those stakeholders. So benefits for staff, co-location of services, enhanced team communications and improved service delivery. Clinical team meetings and extended CTMs facilitate opportunities for multidisciplinary and interagency shared care planning. Service delivery is everybody's responsibility, so less siloed working. Opportunities to work collaboratively with other disciplines, leading to better outcomes for service users and shared learning for staff.
Suzanne, just into the last minute, if we could, thank you.
Yeah, certainly. The benefits to service users include multidisciplinary, interdisciplinary, personalised care planning at CTMs, initially with the service user at the centre. A discussion at a CTM can identify the need for a more detailed extended CTM with the service user or family invited, so the service user or family can tell their story once without having to repeat it several times, and everyone is aware of their needs. The secondary benefit is hospital avoidance and planned discharges as described previously. And the final feedback example I received is that there is a real focus on reduction of duplication. For example, patients attending joint assessments such as paediatric speech and language therapy and OT assessments, where in Network 8 and 9, the OT and SLT are undertaking joint assessments, where parents only have to attend once and to tell their story once, reducing the contact points by nearly half. It's early days yet, but the model continues to roll out. And as that happens, benefits will continue to emerge. And I'm looking forward to working in this new way, which will have its challenges, but we will all have great support from those on the ground. Thank you for listening.
Suzanne, many, many thanks, and thank you to Sonia and to her team in Cork North and East. Particular thank you to our speakers, to Suzanne, who we just heard from, and to Sheila. We're going to move on now to Kerry. Before I do that, I am just going to remind you to submit your questions, and many of you are. We're getting lots of questions in. Email them to changeandinnovation.south@hse.ie. So I'll now hand you over to Julie O'Neill as the Integrated Healthcare Area Manager for Kerry.
Thank you, Mary. My name is Julie O'Neill and I am the Integrated Healthcare Area Manager for Kerry. So firstly, introducing the IHA management team for Kerry. So Mary Fitzgerald is the manager of University Hospital Kerry. Fergal Grimes is the IHA service lead for older person services, primary care, health and wellbeing and social inclusion. Then moving on to Claire Max Sweeney. Claire will be speaking shortly, and Claire is the General Manager for Community Healthcare Area 1, and that is North Kerry, and she will be the General Manager lead for the IHA for older person services. Michael Moriarty then is the General Manager for Community Healthcare Network Area 2, representing Mid Kerry, and he will be the General Manager, IHA lead for mental health, disability and also children's services. And then Niamh Lordan is the General Manager for CHA 3, which is South Kerry, and the GM and IHA lead for primary care and health and wellbeing. So finally there is a vacant post at IHA Head of Service grade for mental health disability. And whilst we wait an appointment to that role, Mary Fitzgerald will be taking responsibility at Head of Service level for mental health services. And thank you also to Fergal Grimes, who will be taking responsibility at Head of Service level for disability. And we'll be shortly able to hopefully announce a permanent appointment into that post. Our business supports then, many of you will be familiar with the IHA General Manager, who is Olivia O'Rahilly, Clinical Projects, Peggy Horan. Our support from the People Office is Mary O'Connor. From Capital Estates is Ken Tobin, and like both Priscilla and Sonia's areas, we're just waiting for some appointments there in terms of finance and QPS, etc. And then finally, our clinical support is our Assistant Regional Clinical Director, Dr. Richard Liston. So thanks, Mary, and I'll hand over to Claire now.
Good afternoon, everybody. Hope everyone is keeping well, and thank you for the introduction, Julie. So I've been asked to speak about IHA Kerry patient flow, and as we understand, when a patient presents to us either to ED or to our services in the community, they're on a journey. So we decided we would look at this and how this flow is working. So in Kerry, we set up a huddle led by Julie O'Neill, and the purpose was really to bring together all the key operation leads across the IHA with the objective to implement a push-pull model, UHK driving proactive discharge and community services, then reaching in and identifying the patients into appropriate pathways. So the format that we decided to take was that we'd hold daily calls every morning at 9:48 a.m. on MS Teams, and the duration of the call lasts very short, only maybe 10 to 15 minutes. It's quick, it's snappy, and it's to determine, what are we going to do with the patient now that they have presented themselves to us. The stakeholders that are involved in this meeting are the UHK operations directors, patient flow from UHK, our community healthcare network managers, the directors of nursing in the community hospitals, our ICPOP and ESD teams, our community intervention team, and our home care support services in the community as well. The approach that we're using is it's a standing agenda. There's integrated review of patient flow across the acute, community and home support pathways, full transparency of bed capacity and community service availability, and ensuring that the bed capacity is full at all times, that no bed is vacant, because we do want to move patients along as quickly as possible, that they're not in an acute service inappropriately. The emphasis of this meeting is on solutions that keep the patient at the centre of the decision making. And I suppose this is reflected now across the region as well. Next slide, please. So I suppose in relation to the huddle, so why patients that are clinically fit for discharge and are awaiting placement or supports are reducing acute bed availability. And should be the aim across the region from the point of view of, again, referring back to Slán to Care and the appropriateness of where somebody is going. They do need to be moved out of an acute setting once they have had their treatment and are fit for discharge. So the key focus is on embedding a safer model of care, going from red to green days, having a plan for every patient and identifying the next step, and also what the impact of that then is on the reduced and trending downwards of the delayed discharge of care for patients, which improves their own well-being and recovery after an event. Next slide, please. So just to kind of demonstrate that, we'll give an example here in a case study. So a palliative patient who was fit for discharge was identified as a delayed transfer of care. The patient could not go home because their housing wasn't suitable. There was other issues such as language and communication barrier with the patient's husband, as English was not the main language, and who was her main carer. The issue was escalated through the IHA patient flow forum, and I suppose the key actions that came out of the discussion and the planned approach. The CHN manager assessed the patient accommodation, advised was not suitable for the patient and as appropriate discharge destination. To advocate for the client, the social inclusion team and Kerry County Council worked together and were engaged to progress housing solutions. So in collaboration with Kerry County Council, the CHN manager arranged for alternative accommodation while permanent accommodation was being secured. The public health nurse was supported the patient in relation to having meals on wheels delivered to the patient. The health and social care professionals, their care continued in this alternative accommodation while the permanent solution was being determined. And palliative care services maintained ongoing involvement as well. So what this shows in relation to an outcome was strong interagency collaboration and rapid escalation enabled a safe interim placement, active progress towards suitable long-term accommodation for the patient. Thank you very much.
Claire, thank you very much indeed. Thank you to yourself, to Julie, to all of the team from the Kerry IHA and indeed from the two other IHAs as well. I really want to thank our speakers. There's a huge crowd on the webinar today, so no matter how well you know your projects and your programs, it is daunting to present it in such a short time to so many people. So sincerely, thank you. It's been really great to see so much news from each of the 3 IHAs. As I said earlier, just a representative of the great work going on right across the region, but just so encouraging that we have a showcase for it here today. And I do think all of the projects we've seen and all of the work we've seen are really great examples of our region's approach to equity of service and delivering care close to where people live. And really what we've seen today is just the essence of integrated work, of delivering on Sláinte care, and of course our 8 integrate commitments as well. So look, the good news is we have plenty of time for questions. Do please keep getting your questions into us on that email address on changeandinnovation.south@hsc.ie. I suppose it wouldn't be a webinar if there wasn't, as I said, like a last minute technical problem to keep everyone on their toes. So unfortunately the Q&A function isn't working, but just so you know, the team at that address, they're collating their questions and they are sending them straight on to me. They're just sending the questions, which effectively means they're anonymous. I don't know who the questions are sent by or where they're coming from. And just linked on that, we see a lot of questions coming through about, I suppose, very specific posts or roles and so on. We'll address those in a very general sense, purely so that we're not identifying anyone or talking in detail about anyone's individual circumstances. So onto our panel, we have our 3 IHA managers, Priscilla Lynch, Sonia Cotter, Julie O'Neill, and they're joined by Deborah Harrington, our Regional Director of People. And if the 4 of you want to switch on your cameras, that would be great. I think maybe we will do a mix of kind of short rapid fire questions and then maybe have a conversation around any of the bigger trends or themes that are coming into us. But maybe to start with, and this is kind of a summary of some of the questions we've coming in, could I ask the 3 IHA managers what will be the biggest change or shift for staff once we come to March 3rd? I know that some of us have seen changes in the last year or so, but for many others, it's been business as usual. They may see, you know, some impacts, but for them personally in their day-to-day, there may not have been much of a change in their role. So for the IHA managers, what do you think is going to be different for staff? And I might start with Priscilla, if that's okay.
Thanks very much, Mary. I suppose, as I said in the opening element, in terms of change impact for staff, certainly have to acknowledge our teams that have transitioned across to the IHA model, that they have been impacted, and it's true professionalism and dedication in terms of how they've embraced that and worked with us collectively as an executive management team to assume those roles. But as we said on other communication forums, in the vast majority, there was very little change in terms of day-to-day of what individuals are doing at the moment. But what we would see, and we hope that certainly it's being depicted from the webinar here today, that as we've moved and are continuing to move into a fully integrated model, we'll be, reducing down dramatically duplication. Communication between teams will be much more linear because in each of our respective IHA areas and our management teams, they will have their own teams, and that will be fully inclusive of all service areas and of all disciplines. So everybody will have a voice and have opportunities of dialogue, and that will only improve the services that we deliver for individuals. So I think it's really important to stress, because I know certainly myself, Julie and Sonia continuously get engagement on a daily basis. Are we asking people who are now presently working in West Cork, where I'm based today, to go across over into North Kerry? No, absolutely not. That's not the essence about this. It's about us constituting our services to deliver care in an equitable fashion as close to where people live, but doing that very sensibly and being very conscious of our our personnel's terms and conditions. But we would see that staff would be very proud of services. This is a great opportunity. Some of the examples we've seen today, outreach of oncology being delivered to peripheral areas. I mean, that's just an amazing thing that we will all be proud of, and that will be stood up next month. So certainly that's what I would see for staff.
Great. Thanks, Priscilla. Sonia or Julie? Sonia, would you like to come in next?
Yeah, thank you, Mary. I think kind of like really Priscilla has covered it off. I think kind of what we're going to see differently as well is kind of more local decision making in a more timely fashion, you know, in a manner, you know. I think when you look kind of, if I was to look at Cork North and East, even within my CHA areas, there's different levels of services being provided in each area. You know, and it's really been focusing in on the population health and the needs, and then being able to actually increase the services for the population needs rather than just location, or rather than just, you know, a kind of a large thing. For example, you know, CH8 requires significant services to be put into it. However, it's very highly, you know, a lot of services are being delivered there on the disabilities. So it's around kind of, you know, being able to make that local decision making for the population needs across the board. Thanks, Mary.
Thanks, Sonia. Julie, anything you'd like to add from the Kerry perspective? What do you expect the changes to be?
So I suppose really our focus is on our priorities, Mary, and you know, across the 3 IHAs for 2026, we need to deliver, and all of our teams, all of our management teams, supported by all of the staff, we need to deliver on the HSE South West component of the NSP, of the National Service Plan for the people both living in Kerry and across Cork. So we will each be coordinating and overseeing improvement plans for each of our respective IHA leads. So for myself, it will be mental health and disability, just for an example. So, but then I suppose more specifically within each of the IHAs, we're focused very much on unscheduled care, on planned care, reducing waiting times for patients. And particularly there are areas of particular focus that we will be putting particular focus on, and our IHA management teams will be doing so, and that's in relation to primary care waitlists, CAMS waitlists, access to children to disability services, respite, etc. So I suppose whilst we would have always had a national service plan, we have an operational plan, a regional operational plan that will be shared with all of the teams shortly. And our priority focus is on a system-wide change in terms of, you know, and development in terms of integration, but a key focus on those areas of productivity, efficiency, etc. So thank you, Mary.
Great, thanks, Julie. I might bring Deborah Harrington as Regional Director of People in now. Deborah, some very specific questions that I'll come to you about in a second. But first of all, from a people point of view, is this a difficult process to kind of steer through, a difficult change management process? And any advice for managers as they're steering their own teams through it?
Yeah, I think to be fair to this organisation, I've been in it since 1999 in many different versions. I think our staff are well attuned to change. I think it's our middle name at this stage. That's not to say the change isn't difficult, but I think our staff are very agile and are used to change. And I think that this has been well, you know, signposted in terms of slowing to care. What we do need to get better at, and in terms of supporting staff, and the HR operating model, which is new and was signed off through the WRC in December last year, will greatly assist us, because we will have specialist pillars around learning and development, and, you know, culture sits in under there as well. And that's obviously so important in terms of, you know, supporting staff to live our values. You know, it might be easy every day. We have supports in around an integrated recruitment function as well. And we're trying to get ahead as well in relation to things like workforce planning. So trying to be less reactive and more proactive around staffing. And I think that's going to be really important in terms of navigating change as well, that people see that there is a change and that things are more efficient, and, you know, that they see that there's a benefit to them on the ground of things like HR operating models coming into play, HR being there within the governance structures, myself at REMT and Ops, the heads of HR, Mary and Anne-Marie at the IHA management team level, and our GMs then supporting the pillars and all the HR professionals that are out there. We have a range of people across all the grades working in HR. I suppose the difference will be we're all in the one family now, and we're all one team working together. And I hope that that will greatly assist and support managers in navigating the change, although I think we have very resilient and agile staff because we're well used to it at this stage.
And Deborah, you might be able to help us out on some of the questions that are coming in. We're getting a lot of, as I said, very specific ones, people either asking about, you know, what are the operational lines going to be for a specific role, R&D people saying, you know, my senior manager is moving, what does that mean for me?
Yeah,
and maybe you could talk us through that.
Yeah, of course. And that's all very live, I suppose. So look, we've met the management teams now. They've got into place. As the IHA managers have referenced, a few people to come into some of the gaps there, but largely speaking, they're in place. And that was step one. As we move into step two, of course, when we move from a world where we had care groups into a world where people's area of responsibility is larger than a care group, there will be changes. However, I just wish to assure everyone that people will be engaged with completely. We have the staff reassignment policy, which was signed off last year, and it's very clear in terms of the steps and the engagement that has to be undertaken. We also have our, our legislative responsibilities, our responsibilities under the public service agreements, and we will always adhere to them. But I would just ask people to, not be nervous because there will be engagement throughout.
And I suppose I might bring the IHA managers in that, because we are getting a lot of questions from people asking about, you know, very specific scenarios. So I suppose maybe if we could give them some reassurance that there will be more engagement, there will be more communication, and we are getting questions from people asking specifically how are they going to find out about things. So if any of the IHA managers want to come in on that process, and I think Priscilla, you might be best placed for that.
Absolutely. So I suppose just to reassure people that we do have the regional implementation group, and as part of that we have representative bodies, we have staff members and obviously line managers. So we'll be working with our teams in terms of the introductions that we did earlier on, and very clearly there will be ongoing communication, ongoing dialogue. But as Debbie indicated, you know, where so far as possible, we would like to kind of eliminate any fear. We intend on being very sensible in our approach and having an open dialogue process with teams right across. And I suppose just to reassure people as well, because certainly individuals have asked, well, they're very good and there are very good practices and processes in place where peers get to connect and communicate with each other, whether that's around supervision, whether it's around development, etc. So we don't have any intention in derailing any of that. We have the director of regional director, of nursing and midwifery. Dr. Peter Carney is regional clinical director, and obviously we will have a health and social care practitioner lead for the region. And they're working hand in glove with our good selves to make sure that we build the clinical governance and that we ensure that we keep that connectivity in place. But certainly we want to be hearing from teams and their viewpoints around how we take a lean, sensible approach as to how we deliver services in the new world from the current march of an integrated service. And as I said at the beginning, this isn't change for the sake of change. This is change that we all wear the badge of honour of being the HSE staff, which I know an awful lot of us are dedicated to services and proud to work. So it's how we improve that.
So I just see some very specific questions coming in, and in the few minutes left to us we might do just two rapid fire questions and then one broader one. And the first is, and I think this is maybe for any of the IHA managers who'd like to jump in, just to briefly explain what is the difference between an ISD lead and an IHA manager. And again, these are terminologies that people will get more familiar with as we use them, but if someone just wanted to briefly do a sentence on that. Priscilla or Sonia?
Okay, so an IHA manager is, there are three of us in the region. An IHA manager is an integrated healthcare area manager. So Julie, Sonia and I are integrated healthcare area managers, and we have responsibility for each of our respective IHAs, the population and the services within those in the operation of those services. An ISD lead be that at head of service or general manager, are the individuals that report directly to us and our management team that we introduced earlier on. And our respective colleagues on our management teams hold a portfolio brief or a geographical area that they in turn are responsible and accountable for delivering those services within our respective areas. And certainly post today, and once our teams are established, we will absolutely be sending out the details and the contact details with regard to our respective team members.
And I think that is the point. Once we see this being operationalized, it will become more real for people. And obviously there will be an ongoing process of communication. Very conscious of the time, and I know people will probably have to leave at 2 o'clock on the dot. So just before we finish up and sum up, I have a question just in asking about equity of budget across the 3 IHAs. So I know people might expect that there'd be, a division in 3, but obviously it'll be population based. Anyone briefly want to explain how that's working?
Yeah,
Julie, would you like?
come in?
Yeah, thanks, Sonia.
Yeah, I'll come in there, Mary. So there'll be equity of budget in regards, but it will be population based. You know what I mean, and also services based. If you look kind of at like we have, a lot of like our Model 4 obviously will cost a significant more than the Model 3s, the Model 2s. But going forward, each IHA manager, we have a financial budget. We will have a budget for each of the areas, and we also have a WTE cap. So for us, we have to live within that. We have to live within our budget and live within our cap. But that's the good news as well, because that means that we're able to kind of prioritize the priorities that Julie outlined there. We will be able to, if we need to increase resources to a certain priority, we'll do that. But I think the budget will follow the activity.
Perfect. I can see that we are just past the 2 o'clock and I know that people will be moving on to other meetings. So I'm just going to remind everyone before we sum up fully to thank everyone for attending, to really thank the team behind the scenes, to thank our speakers and our panel for taking the questions so openly and those who submitted questions as well. A reminder that this is recorded. You will be able to watch it on the HSE Southwest YouTube channel next week and do please encourage anyone who couldn't make today's event to have a look, and a reminder that the slides will be circulated as well. Keep an eye out for further updates. There's been several in recent months and there will be more coming. So unless there's anything else pressing or if anyone wants to add anything else before we finish up, I think we will leave it there. Again, thank you very much for your engagement. Priscilla, I see your hand up. So if you want to come in.
I suppose, Mary, just to give people an opportunity, given that the chat function was not available today because of the technical difficulty, that if individuals want to send the correspondence to, or any queries that they have that we might be able to assist with, then please do so to the email that's in the chat function there and that you've been using today, and that we could endeavour to go back into comments with responses that might aid some of their queries.
And I think people would really welcome that because this is part of a process. It's an ongoing process. Thank you very much, panel. Thank you so much for taking the questions. I know they were thrown at you quite rapidly. Thank you to everyone for coming on. Huge crowds on, and thank you to the engagement. Best of luck all. Thank you.
Thanks, Mary.